afternoon, colleagues. We have a discussion today on managing incontinence. We're taking a view from an expert medical expert and a legal expert on what is a very controversial and difficult topic. I want to introduce my panel today. Professor Veronique Phe is Professor of Urology in Paris. She was the first female professor of urology in France, and she is a member of the EAU guidelines on female urology. And we are also joined by Mr. Bertie Leigh, who is a solicitor, an expert in medical legal cases and medical law, who is a member of some austere medical associations. He's an FRCA fellow of the Royal College of Obstetricians and Public Health Physicians. So without further ado, Mr. Leigh, I might address you first. One of the great difficulties for a practicing urologist when they're preparing patients for surgery is how much information must they disclose to be sure the patient understands fully what their operation will entail.
I think there's a fundamental mistake, Eamonn, in people thinking that the law's demands are for patients to be warned of risks. It is, of course, a part of it, but it's a very small part of it. The whole of the law has been shaped, and practice has been shaped by the concept of the law of assault, and that you have to defend yourself against a charge of assault, which means the patient must consent to a risk. But in practice, none of the patients I come across ever sue doctors because they didn't consent. What they complain about is that they weren't warned properly, they weren't counselled appropriately. And when you give people information, it's essential that you provide information in a way that they can use it. It's got to be suitable to their language, their educational status. It's got to be appropriate for the circumstances. In England, we get people to sign a consent form on the day of surgery when they're acutely frightened. We give them information in hieroglyphics and abbreviations, which we know perfectly well they can't understand, like DVT, and think that in some way it has a legal value. Because it's been a requirement of practice for so long, it does have a legal value in the sense that you get into trouble and it's going to be harder to defend you if you haven't got a consent form. But as evidence of the quality of communication, it's very poor, because what we need is to be given information not only about the risks, but about the alternatives. And the alternatives that we face depend upon the circumstances. If I'm told that I've got a space-occupying lesion in my head as a result of an RTA an hour ago, and that I'll be dead in the morning, I don't really need very much information. But on the other hand, if I've got incontinence, then the chances are that I'm either over-presenting or under-presenting my symptoms according to whether or not I think that you can offer me an effective therapy. And what you have got to do is to get into my head the real options available to me. You've got to get a fair presentation. If I carry on lying and telling you something different about my incontinence, of course, legally you're entitled to rely upon that. But in reality, if you're going to give me a high-quality consenting process, you've got to give me a high-quality teaching exercise. You've got to teach me what the options are and impart information in a fashion that I can use. That's the problem.
But I understand consent protects you technically from the battery, from assault, but you can also, if a fear for doctors is if they don't mention a complication and it happens in reality, that they'll be sued for breach of duty of care under tort of negligence.
It depends on the complication. One of the things which exasperates me is when people use analogies from the airline industry and say, look, the airlines have made flying so much safer, we should be doing the same with medicine. the difference is that medicine isn't practiced at 30,000 feet in an empty sky. The airline industry never lose a patient unless the operating theatre falls out of the sky, and it never happens. When the airline industry can start keeping control of my luggage, then they can start teaching me about the meticulous care that medicine has to apply. Something like 10% of luggage still goes astray, and the airline industry is hopeless at dealing with this problem, obviously. So what I think we ought to be doing is getting inside people's heads, conveying to them the information that Veronique has and that she thinks that is really relevant to their problems. Of course, she's got to mention the risk of death if it is something more substantial than the chance of the operating theatre falling out of the sky. But she doesn't have to mention it in every minimal procedure, which is not.
So for example, if I'm performing a circumcision on a fit male athlete, do I mention the possibility of death?
No, of course you don't.
No.
I don't know whether anyone's died having a circumcision. I suppose they might have done, but if so, it almost certainly was an anaesthetic death, and the gas man's going to counsel them separately.
Okay. That's good. Thank you very much. Turning to you, Professor Phe, on that point. I mean, you deal with very difficult and complex cases of urinary incontinence, particularly reconstructing catastrophic incontinence. And from this morning's session, we'll use the example of mesh and mesh complications. How do you approach your decision? How do you communicate with patients? Do you have a policy of shared decision making in these cases? How do you inform the patient?
Yes, of course. I think that the shared decision making is really the most important point in the management of female patients and also male patients, but in the field of functional urology, because we are not really saving their lives, but we are here to improve their quality of life. So it means that you have to understand how they live in order to meet their expectations of the treatment or how you are going to deal with the complications. They have to be aware of what you are doing, but what it will involve, what it will impact on their daily life, on their continence. So the shared decision making is really important. They have to expose, how they live, what their occupations is, what sports they practice, if they've got children, if they are isolated or they have a family around, etc. So you have to be really curious about how the patient lives in order to meet their expectations.
Would you bring the partner in routinely when you consent a patient or discuss a complex procedure? Is it a good idea to have a partner present as well?
Yes, of course, but it's quite interesting to have the partner present. Perhaps not for everybody, because sometimes you don't want your partner to know that you're leaking, that you've got limited sexual activity because of that. So it's not very so easy to have the partner close to the patient. However, in all patients, it can be interesting to have the partner also, because the partner is here to help in everyday life. So yes, I think that being a doctor, it is really important to be curious about how the patient lives.
Yeah. Their values, and you obviously take that into consideration in your practice, and that's
the most important.
And I think, Mr. Leigh, patient autonomy is very important. That's enshrined in medical law, isn't it? That's the patient's rights, and patient autonomy is critical in consenting people for surgery, and reflecting their values. What maybe might not seem significant to a doctor, but significant to a patient. Is it fair to say that case law, the judges look on that the patient's perspective, the patient's view has been taken into account?
Certainly. patient autonomy is now a fundamental principle of law, as it is medicine, I think more or less everywhere. But you've got to take your autonomous patient as you find them, and you've got to include their vulnerabilities and their difficulties. You talk about whether or not the partner should be present. That depends very much on the patient. There are some patients, especially as we get older, who very much need their partners with them to help them. There are other patients who have secrets from their partners or things that they would not wish to discuss in front of them, even if they're not carrying on an affair with another person. They may be very shy about their incontinence and not want to reveal that to the patient. As Veronique says,
Yeah.
you want to you've got to take the patient as you find them. And it may be a good idea to have separate interviews with the patient and the partner, but that's a matter of medical judgment rather than anything useful. But yes, the basic principle that autonomy is fundamental, but you've got to put your patient in a position where they have the knowledge that you have that they need to exercise their autonomy. You have to be aware of the alternatives available to them, the alternative surgical treatments, the alternative medical treatments, the alternative of no treatment. And you've got to enable the patient to understand, and this is particularly true in the area where Veronique practices, which is subjective, where she depends almost entirely on what the patient says about her symptomatology. That's very difficult.
Yeah, thank you. Professor Phe, just do you think, with your complex cases, is there a multidisciplinary team process or an interdisciplinary discussion about these cases? And do you think the process of MDT, as we call it, interdisciplinary discussion, is a robust way of managing patients?
MDT meeting, I think it's absolutely mandatory in our management of complex cases, because you have to understand the whole story from the beginning, the complaints, till the end, till the complications. And so you have really to gather all the pieces of evidence to understand what happened and to offer the best treatment to the patient. So the MDT meeting is also an opportunity, a moment where we are going to expose all the gathered evidence to see if there is something missing, to see if, of course, I can see that I'm the best surgeon. I can say that I'm the best surgeon, but if I can fail, I can forget asking something to the patients. And so the MDT, the team, is here also to remind me, you've forgotten to ask this to the patient, etc., etc. So it's good to have also other advisors. And then we have to discuss about the different strategies. It doesn't mean that if you recommend something that the patient will follow the recommendation. It's just an advice.
Okay.
After, you have to return back to the patient to explain to her or to him what the decision is, what the suggestion is, I may say.
Okay.
And then discuss with them the expectation and the impact.
Okay. So you do, even for, they're very obviously common and almost, urologists see them as mandatory with cancer management, but you would use it with complex functional urology as well.
Yes,
Yeah,
yes,
thank you.
it's mandatory.
What's, urologists think that a multidisciplinary team meeting is a great protection, that, taking soundings from colleagues is a very safe, it's almost a standard of care, certainly in the UK and Ireland and in the United States and indeed in Europe. What's your views on it from a legal perspective, Mr. Leigh?
Well, I have very mixed feelings about an MDT, and I think it depends on what you're trying to achieve. In England now, it's pretty well mandatory to have an MDT, for example, in any cancer case. But it doesn't provide any protection. The last case I did involved a liver surgeon who took a case to an MDT twice. They said that because there had been a change in the liver function, he should have taken it back a third time. I say the allegation was refuted, but nonetheless, there is no protection in an MDT. I think there is something disproportionate about a doctor who knows perfectly well what they want to do in a routine case, and they then take that case to an MDT where it will be discussed by between 20 and 40 people. Only one other, or maybe no other, has met the patient, and the patient isn't present. If the MDT decides to do something that the presenting doctor doesn't think is appropriate, or if the condition changes, the presenting doctor is in a very difficult position. Should they flout the advice of the MDT, or should they proceed to do something that they don't think is appropriate? I think there's also an economic problem. We, at the moment in England, have a crisis in the financing of the NHS, and I think that is a pretty international phenomenon. And yet we assemble 20 or 40 people in a room for a whole morning to discuss a series of cases, often very briefly, sometimes only for a couple of minutes. That is very expensive. It's also very cumbersome in the case of urgent diseases like cancer, because you have to wait for the next MDT where you can squeeze it in, so there may be delays. As I say, there's enormous expense. Very often it's a rubber stamping exercise. Everyone knows what the decision is going to be, and the discussion lasts less than 2 minutes. I wonder what value you're going to get from this. It may be teaching. You may think that there's some teaching value, but this is a series of very short discussions of case presentation.
So from a legal perspective, would you change the MDT process?
Yes, I think that...
What would you recommend?
Well, I'll tell you what I really think would be sensible. If we could go back to the old-fashioned consultant dining room, where the consultant, when they had a difficult decision and they went into the dining room, they would steer for the person whose advice they wanted. And you then get an MDT discussion. It will cost the service next to nothing, and it promoted the esprit de corps of the consultant body. I know nowadays that people think that that's elitist and inappropriate. Medicine is an elite sport. It may be surprising to people to know that I don't want to be treated by somebody who's practicing their skills in democracy.
Last quick question, though. I mean, would it stand up in court? Your recommendation?
Sorry?
Would that stand up in court?
What you've got to do is to defend the quality of the decision-making. Yes,
yes.
There is no law about an MDT, and very soon we're going to have people asking questions in court about, well, what did happen at the MDT? What information was given to them? Were people really paying attention? Because I'm quite sure that very often they are not.
Okay, we must conclude there. I want to thank you both, Professor Phe, Mr. Leigh, for a great discussion. There's so much we could talk on this subject, but time has come against us. So again, thank you very much. Thank you.